All right, it looks like we are recording. So welcome to our week 6 live session. I just noticed another typo here. I apologize for all of my typos. This is MCCG223. This evening, we are going to go over anesthesia, radiology, and pathology laboratory coding in the CPT codebook. So 3 kind of disparate sections, but they are 3 completely separate sections in the CPT codebook. So it's kind of a lot to go through. I'm going to try to stick to an hour as much as possible. The good news is that they are not the most complicated sections of the CPT codebook. There are guidelines. There are some general kind of coding rules that we need to pay attention to when we're coding from these sections. But we're gonna go through kind of those high points today and do a lot of practice. There is, I believe, 42. Looks like there's 42 slides on this slide deck. I don't know if we're going to get through all of these. So I will very likely skip a couple of these, and then I will post the presentation in the announcements. And so for those ones that we've skipped, if you want to, you can go through and kind of code those out because the answers will be here on the slide deck. So without further ado, I'm going to go ahead and get started. So let's start with anesthesia. Okay, anesthesia coding is its own section in the CPT codebook. You can see I'm sharing my camera. So you can see my CPT codebook here. So I have my own little tab on anesthesia coding. I would definitely 100% suggest you tab your books. Anesthesia, the section itself is quite small. It's only a dozen or so pages. And the codes themselves are relatively straightforward. So when it comes to anesthesia coding, the thing to remember is that we're not coding for the surgical procedure. We're coding for the anesthesia that the anesthesiologist administered to the patient so that the patient can undergo their surgical procedure, to anesthetize them during that procedure, right? So that they don't feel pain. So there's a couple of different types of anesthesia. There's general anesthesia, there's regional anesthesia. There's also moderate sedation, which is a different kind of anesthesia, I guess you could call it. So general anesthesia is what we're coding in this section of the book. So this is the general anesthesia where you're just completely out, right? This is where the patient is intubated. It affects the whole body. It causes a complete loss of consciousness. So the patient literally can't even breathe for themselves most often, right? The anesthesiologist is assuming those functions for the patient. It's typically administered by injection, inhalation, instillation, or a combination of these techniques, again, administered by an anesthesiologist. So that's kind of what we're coding for when it comes to the services in this section of the book. And this is what you would consider anesthesia. There's also up on the screen, it talks about regional anesthesia. This is anesthetizes a particular area or region of the body, and it's typically it is accomplished through nerve or field blocking. So the difference is it's typically going to be injected into a specific area or nerve in the patient, and sometimes done to facilitate a surgical procedure or other procedure, and sometimes done just for pain management purposes, right? Okay, so a good example of this would be an epidural injection. An epidural injection is administered into the epidural, I think it's laminar interspace of the spinal column. Um, and it anesthetizes the bottom half of a patient, typically done to facilitate childbirth, right? You get your epidural, it anesthetizes you, it numbs you pretty much from the waist-ish down. And that's regional anesthesia, right? There are general anesthesia procedures for childbirth, but I think more often than not, we use regional anesthesia. So that's the difference. There is also moderate sedation. I don't think I have a slide on moderate sedation, but moderate sedation is typically used. It's also called MAC. Oh gosh, don't. completely just went blank as to what MAC stands for. It's modified altered consciousness or something like that. Those are those anesthesia procedures are going to be located in the medicine section, and those are typically done like in the emergency room where you kind of just knock somebody out so that you can like relocate their shoulder, for example. Monitored sedation. Other uses of monitored sedation would be during a colonoscopy. Patients get monitored sedation. Oh yeah, I'm looking at your chart. Epidurals are not fun. I've had 4 kids, and yeah, 3 of those I had with epidurals, and one of those I had with nothing. So it's a you never know which one is better, honestly. Okay, so lots of different types of pain management or anesthesia, but what we're talking about here is the anesthesia services that are included within this section of the book with the blue edged page, right? So we're talking about general anesthesia. Let me talk about this for one more second. If you do end up working for a pain management procedure, a pain management or anesthesiologist, I guess I should say don't get those two things mixed up, right? Pain management, a lot of times they will perform regional anesthesia just for pain purposes. They'll also do a lot of like nerve blocking. Last week, I think it was, we talked about Botox injections and chemodenervation of nerves. They will do things like that. They'll do injections into the spine. They'll insert neurostimulators, that kind of thing for pain management. That's different than an anesthesiologist working for an anesthesia. You're going to be pretty much focusing on this section of the book. Okay, so anesthesia HCPCS modifiers. I added just a little clip here. These are often required by Medicare and may also be required by some other payers. So when it comes to anesthesia, there's a number of different providers that could perform this service. Maybe not a number of different providers, but there are at least two different providers that can perform the service. So an anesthesia service can take hours and hours and hours, right? It takes as long as the surgical procedure takes. So one of the things that anesthesiologists will do is to kind of bank their time, so to speak. They will employ CRNAs. CRNA is a certified registered nurse anesthetist. So RN, so they're a registered nurse, but they're a certified registered nurse anesthetist, right? And so these providers are, oh, it's written out here, certified registered nurse anesthetist. So these providers can be, so like, let's say we have one patient who's started their anesthesia, the anesthesiologist determined the cocktail, got all of the calculations correct, started the patient on anesthesia, and then the CRNA takes over. And the CRNA follows the anesthesiologist's plan and monitors the patient throughout the next 3 hours, right? Meanwhile, that anesthesiologist is going and doing the same thing for 2 other patients, for example, right? So in that case, here you have a CRNA anesthesia service that's being monitored by an anesthesiologist, by a physician, but really they're just kind of they're following doctor's orders, so to speak. And so other circumstances might be where that anesthesiologist is herself, the doctor is performing the anesthesia on that patient, right? There's no CRNA involved. So that's kind of what all of these HCPCS modifiers identify, right? AA should be appended when the anesthesia service is performed personally by the anesthesiologist. It's only used by the anesthesiologist. Let me see. I have to group these other ones together. Okay, so G8, G9, that's monitored anesthesia care. That's what MAC stands for. There you go. So that's for MAC. But then if we look at these other ones, AD, medical supervision by a physician. Okay, so AD is used by the anesthesiologist, and they use AD on the exact same anesthesia code as QX, which is the CRNA service with medical direction, right? So it's almost like billing by multiple providers, billing the same service for multiple providers, and it's almost like breaking it up into multiple pieces, right? So the CRNA reports their service with QX, And then the anesthesiologist reports their service with AD. AD identifies that medical service supervision by a physician for more than 4 concurrent anesthesia procedures. QK is medical direction of 2, 3, or 4 concurrent anesthesia procedures involving qualified individuals. So it depends on how many procedures the anesthesiologist is supervising. 4 or more, or 2, wait, yeah. More than 4 is AD. QK is 2, 3, or 4. Sorry. So it can get a little complicated, right? So let's see, that's monitored anesthesia, that's MAC care. QY is medical direction of 1 certified registered nurse anesthetist by an anesthesiologist. And QZ is a CRNA service without medical direction by a physician. So anyways, just pay attention to who performed the service, whether or not it was monitored by a physician. If you're billing for the physician portion, then you have to identify how many different anesthesia services was that physician monitoring, right? And all of that should be documented. Goodness. Okay, so yeah, that kind of goes really deep into kind of a rabbit hole into HCPCS modifiers. What I would suggest here is, or what I would note here is that none of these modifiers are in your book, right? So I would suggest you could probably write them here on page 65 of your CPT code book. There's a nice little section here in the anesthesia guidelines section. You could also write them in Appendix A. At the end of Appendix A, I believe there's a pretty good little section. Yeah, there's a good section like blank space where you could write these. I do not believe that they are going to show up on a CCS, CCA, or a CPC exam, but you never know, not to mention the fact that they're good to know, right? And again, they are required by Medicare and they can be required by other payers. If you don't include those modifiers, you're not going to get paid. Okay, you never thought you needed to know that much about anesthesia modifiers, right? All right, let's go to the next slide. Codes. Okay, so the codes themselves, we're going to go into the formula here a little bit. The codes themselves are anatomically organized. You can see that and we don't really have a table of, oh yeah, we do have a table of contents. Here we go. It's on page 63. Head, neck, thorax, right? So again, as most sections of the CPT code book, it goes from the top to the bottom, up to down, head, neck, thorax, intrathoracic, spine and spinal cord. And remember, when it says head, we're not performing the procedure on the head. We are anesthetizing the patient who is undergoing a procedure on the head. And the surgeon is going to bill for the head surgeon service. We're just billing for the anesthesia because we're reporting that anesthesia code. Now, I don't have it on these slides, but I will say these codes are really general, right? So you've got like anesthesia for procedures on nose. Okay, cool. Anesthesia for intraoral procedures, including biopsy. Anesthesia for procedures on facial bones or skull, right? So the codes are not very specific. So in the real world, if you ever are working for anesthesia, you will use what's called an ASA crosswalk. ASA is the American Society of Anesthesiologists, and they have a crosswalk, right? So like if it is a cleft palate surgery, and it's identified with a specific CPT code, then you'll look up that CPT code and it'll tell you exactly which anesthesia code to use, right? Other than that, for our purposes, it's really just kind of like, it's very general. The code's descriptions are pretty general. What else? Let's talk a little bit about anesthesia. Anesthesia time. I don't know. Yeah, we'll talk about all this. So we're going to talk about anesthesia time. Qualifying circumstances are modifiers. We talked about our CRNA modifiers and MAC modifiers. Oh, we talked about all the modifiers, not all of them. We have a few more to look at. And then the formula for payment. Okay, so anesthesia formula for payment. And one of the things here that's interesting to note is, so let's say we're doing I'm just going to pick one. 0050, anesthesia for all procedures on esophagus. Cool, we're doing an esophagus procedure. Sorry, the surgeon is doing an esophagus procedure, right? let's say the surgeon is doing 2 esophagus procedures today. One of our patients is 25 years old, very healthy male patient, no comorbid conditions, excuse me. Our other patient is 85 years old with 12 chronic conditions, right? And they're on multiple different medications. So the surgical procedure itself is the same, right? It's going to be whatever this esophageal procedure is, right? The anesthesia, or rather, I should say, the surgical procedure is the same. The surgeon can report an increased procedural service. Let's say the service on the 85-year-old patient takes twice as long and the patient's maybe extremely medically fragile, and the provider has to do extra work. It takes extra long. There is modifier 22 that the surgeon can report on the CPT code for the surgical procedure to report that it's an increased surgical procedure, right? However, on anesthesia, it's the same code, 00500. It's the same code for our 25-year-old patient versus our 85-year-old patient, right? You cannot use modifier 22 to identify an increased procedural service on an anesthesia code. So what we do is we use time units and modifying factors, physical status modifiers and qualifying circumstances, and we add those all up. We multiply it by the conversion factor, and then that's how much we expect to get paid. It's actually kind of interesting if you think about this, right? So the time unit value. So let's look at our 25-year-old patient. Let's say it took that patient 15 minutes. Or rather, the patient was under anesthesia for 15 minutes. In that case, you would use 1 unit, right? 1 time unit. On the other hand, let's say for our 85-year-old patient, it took 2 hours, right? So that's, and again, time units are reported in, generally speaking, in 15-minute increments. So if it took our 85-year-old patient, or rather, I have to watch the way I'm saying this. If it took our surgeon 2 hours to complete the surgical procedure for our 85-year-old patient, and we had 2 hours of anesthesia time, then what is that? 4 units, right? It's the same code, 00500 times 1 for a 25-year-old patient, or 00500 times 8 for our 85-year-old patient, based off of those time units, right? So that's one way we can increase that service charge. 2 other ways are our physical status modifiers and our qualifying circumstances. Physical status modifiers are listed on page 65, and they are modifiers, right? Our P modifiers, P1 through P6. P1 is a normal healthy patient. P2 is mild systemic disease, severe systemic disease. P4 is severe systemic disease that's a constant threat to life. P5 is a moribund patient who's not expected to survive without the operation. And P6 is a declared brain dead patient whose organs are being removed for donor purposes. They anesthetize brain dead patients just in case, right? And so those modifiers are added. So let's say our 25-year-old is a normal healthy patient. It would be 00500 modifier P1. However, this 85-year-old who's got, let's see, severe systemic disease that's a constant threat to life, that's a modifier P4. So that would be 00500 P4. Again, right? So you can see how this kind of starts to build on itself. And then qualifying circumstances. Now, qualifying circumstances are also on page 65. They're in that anesthesia guideline section. There are 4 different codes. They are all add-on codes, and they are added onto the procedure code, the 00500, whatever that anesthesia code is. And they report specific circumstances that might, again, increase the anesthesia service that we're performing, right? So 99100 is, I'm gonna make this a little bit bigger. Can't even see it, can you? Patients of extreme age, younger than 1 or older than 70. 99116 is anesthesia complicated by utilization of total body hypothermia, so that would be low body temperature. 99153 is utilization of controlled hypotension, which is controlled low blood pressure, and 99140, which is complicated by emergency conditions, right? Whatever, and then documentation must specify those emergency conditions. So again, our 85-year-old patient, he's going to have that 99100 qualifying circumstance code, added to the 00500, which is going to again add up into a larger base amount for charges. That the charges being based off of what are called relative value units. Those are all added up. We multiply it by the conversion factor, and that gets us to our total reimbursement amount. The conversion factor is a dollar amount. So all of these are just arbitrary numbers, right? The units and the physical status modifiers and the base unit values, all that stuff, right? These are just numbers. So let's say for our 25-year-old patient, he's got a base unit value of 2, and then our 85-year-old patient has a base unit value of 10, right? Just as an example. So our 2 for our 25-year-old would be multiplied by the conversion factor. The conversion factor is a dollar amount that is determined by CMS every year. It changes every year by a couple of dollars usually, and that's the conversion amount. So it's usually like, let's say $35, right? So for our guy that's 25, it would be 2 times $25, so it would be a $50 reimbursement amount. For our 85-year-old, it would be 10 times 25, so it would 35, so it would be a $350 reimbursement amount. I don't know if my math just worked out right there for a minute. I don't math well. So hopefully this makes sense. Anyways, I know I'm kind of really going into depth here for this anesthesia formula for payment, but it just shows you how all of these different little things, reimbursement for anesthesia is quite different than reimbursement for regular CPT or fee-for-service coding, because you add up all of these little components in order to identify the expected reimbursement amount. 8 units. There you go. Thank you. Sorry, I'm just barely looking at the chat. Let's do one of these, and then I'm going to switch gears to radiologies just for the sake of time. Do we want to do a hysterectomy? Cesarean delivery. Let's do a liver biopsy. No. Craniotomy. There we go. Let's do Miss Jackie Edwards. So I'm going to move this guy up. So I just skipped a bunch of these. I have a bunch of anesthesia practice in here, so you guys can look at those as I post the slide deck. So our patient is Jackie Edwards. Date, September 19th. Procedure is a craniotomy. This 38-year-old female has a hematoma, and a craniotomy was performed for the evacuation of the hematoma. She was placed under general anesthesia. So what are we going to look up? You guys tell me, what is the main term that we're going to look up in the index here? Are we going to look up craniotomy? Anesthesia. Yes, good guess. So what are we doing? Are we doing the craniotomy? No, we're not doing the craniotomy. The surgeon's doing the craniotomy. The surgeon's going to bill for the craniotomy, right? We're doing the anesthesia for the craniotomy. So let's look up that word anesthesia. If you looked up craniotomy, it would give you the CPT code for the surgical procedure, right? That's not what we want to bill for. Okay, so look up the word anesthesia. I am on page 1100. And now you can see, just kind of hang out here. And I always say this, like once we get to the index, I am not really very good. After 20 something years coding, I'm not very good at this CPT index. So I really like to kind of just scroll through and see just kind of how things are organized, right? Like you've got chest procedures here, you've got amniocentesis, like arthroscopic procedures, right? So things are kind of organized a little differently here, either by purpose or type of procedure or specific procedure itself, right? So I'm just going to look up craniotomy, which I am finding on the top left-hand column on page 1101. Craniotomy. So we did anesthesia, comma, craniotomy. Oh, look, it's actually at the top of the page right there. That's kind of funny. Craniotomy, ... 00211. We're not going to code from the index, right? So we're going to go ahead and verify it. Okay, on page 66, 00211. So it's a child code here. It's, anesthesia for intracranial procedures, craniotomy or craniectomy for evacuation of hematoma. Perfect, right? 00211. Yeah, there you go. Perfect, beautiful. You guys are good in the chat. Okay, what's next? I have one more, but again, I rambled for about 30 minutes, so I'm gonna skip this last one and we're gonna move on to radiology. All right. So radiology. Radiology is its own section of the CPT code book. Again, you should have a little tab here that says radiology. It's this red section. It starts on page 521. So switching gears here. And if you've ever had me in class before, you know, I always say this. Every time you go for, there's 6 sections of the CPT code book, right? There's E&M, anesthesia, surgery, radiology, pathology and lab, and medicine. 6 sections, right? And all of these sections are divided based off of procedure type. We just looked at anesthesia. Now we're going to look at radiology. After this, we're going to look at pathology and lab. And so as you go through all of these different sections, well, the sections are organized based off of like common procedure type, right? So it follows that as we go through all of these different sections, you kind of have to put yourself in a different mindset, right? So in that anesthesia section, we're in the anesthesia mindset, right? We're not coding for the surgical procedure. We're coding for the anesthesia that the anesthesiologist, you know, put the patient under so the surgeon could do the surgical procedure. So anesthesia is kind of different, right? Radiology is also different. We're not actually doing anything to the patient here. The vast majority of radiology codes are considered diagnostic, meaning they're performed to diagnose health conditions, right? We're taking pictures of the insides of patients, essentially. There is a really small, maybe not a really small, but there is a section of therapeutic radiology codes in this section of the CPT code book, and that's going to be what you would consider radiation oncology. Those are very complex codes. You're talking about calculations for dosing. It's called dosimetry, kind of a cool word. Calculations for dosing radiology for patients, brachytherapy codes, which is like implanting little radioactive seeds inside of the tissues of patients, right? And actually delivering radiation oncology. So there is some of that therapeutic stuff in radiology section. But the vast majority of this is diagnostic. Lots of different diagnostic procedures, or diagnostic imaging studies, I should call them, right? X-rays, CT scans, MRIs, ultrasounds, fluoroscopies, nuclear imaging. And again, they all kind of take pictures of the inside of patients, right? Here's our code sections. Again, diagnostic radiology. The thing with diagnostic radiology, and let me yeah, diagnostic radiology includes X-rays, CT scans, and CAT scans, I believe. Then you have ultrasounds. Radiologic guidance can be used either fluoroscopically, I guess I should say, or ultrasound guidance. And that is used to facilitate a procedure. Like let's say we're doing a large joint injection into the hip joint, and the provider uses ultrasound guidance to make sure that they're guiding the needle into the interspace of the joint and they're not like hitting a bone, right? So that's radiologic guidance. Mammographies, bone and joint studies like bone age studies, osteoporosis studies. There you have your radiation oncology and the nuclear medicine. There's going to be like PET scans and other nuclear medicine scans, typically for to evaluate cancer growth or spread. Okay, when coding for radiology, you want to ask yourself the following questions. Now, radiology coding is not exceptionally like complicated, right? We just have to pay attention to what was done, pay attention to these questions here, and make sure everything matches up. And it's very kind of, it's not complicated, but it is detailed. Working in the real world, the vast majority of our radiology services are denied Usually due to the diagnosis code, because the diagnosis code doesn't support the medical necessity for the service. So like, for example, our doctor will order a chest x-ray with the diagnosis of headache, right? Like insurance does not consider a chest x-ray medically necessary for purposes of a headache, right? So diagnosis coding is important. And then also the other thing, we see lots of denials based off of this modifier, right side, left side modifiers, and not matching up with the diagnosis. So those are kind of just some kind of tips for the real world. As far as code selection is concerned, the first thing you want to identify is what is the type of service, right? Is it an X-ray, a CAT scan, an ultrasound, a mammography, PET scan, nuclear medicine? What is the type of radiology service? Next thing is what area of the body was imaged. Okay, so we're taking pictures of the patient, right? Well, what are we taking pictures of? The whole body? Some of these codes do, like nuclear medicine. You can have a nuclear medicine study of the entire body. But it's more often than not, it's a very specific body part, right? The leg, the arm, the toes, the thumb, the abdomen, the pelvis, the chest, right? So what area of the body was imaged? If it is a, what's the word I'm looking for? A paired organ. Arms are paired. Breasts are paired. Eyes are paired. Right. So paired meaning you have a right side and a left side, right? So if that's the case, you want to make sure that you identify sorry, my husband just called me. He's on a road trip. I gotta text him back here a second. You want to identify the laterality of the procedure that was performed by using the appropriate RT or LT laterality modifier. Hang on. Hold on. Hold, please. Okay. Sorry. I apologize for that delay right there. Okay, so yes, make sure you utilize the RT-LT modifiers if it is a paired organ on which you perform that procedure, right, on one side. Some procedures will be identified as bilateral. If that's the case, then you have to perform them bilaterally. If not, always pay attention. If it's a paired organ, again, which side did you perform the procedure on? And according to the code description, does the code description state, right, unilateral, bilateral, and do you need those modifiers? Okay, next bullet is how many views were involved. Views are essentially how many different pictures did we take, right? So there's like from the front to the back would be anteroposterior, from the side would be lateral, right? You could go from the top down, from the bottom up. You can do all sorts of weird twisty things. So essentially how many views, how many pictures are performed. Very common with x-rays. So it is usually going to be a component for our x-ray codes, but it's not a component with like CT or CAT scans, because that's kind of a more, it's a different kind of it's a different procedure where views really aren't necessary, right? Aren't performed. So you're going to see how many views were involved. That question will have an answer for some procedures like x-rays, but not all procedures. Another thing you're going to see is limited or complete. Sometimes you will see the differentiator in a code description that says a limited study or a complete study, and that'll be defined by the code set as well as your documentation. Okay, next bullet down. Was the procedure performed with or without contrast? So again, this is all hopefully just kind of reminders, right? With or without contrast. Contrast is material that is injected into the patient. It is not breathed in, it is not consumed, it's not swallowed, it's actually injected. Okay, and I'm going to show you this because this might come up because it's a tricky little part, might come up in a like a coding exam. Especially like a certification test, right? So if you go to page 525, you have, this is our surgery, I'm sorry, not surgery, our radiology guidelines section. And there is a section here that says administration of contrast materials. It says, the The phrase with contrast used in the codes for procedures performed using contrast for imaging enhancement represents contrast material administered intravascularly, intraarticularly, or intrathecally. So essentially what that means, it's injected, right? If I'm going to skip a lot of this stuff, but if I go over to the right-hand column, the very last little sentence says, oral and or rectal contrast administration alone does not qualify as a study with contrast. So if you know this is some sort of like a, I don't know, swallowing study and the patient swallowed some sort of contrast material, that, yeah, technically it's contrast material, but for the purposes of code selection, it does not qualify as with contrast. Okay, so just make sure that you remember this guideline. Okay, and then the last bullet here is which component was completed. I don't think, hang on a second. I thought I had, hang on a second. I thought I had a better slide. No. Okay. I'm just going to talk about it here. So, and I know this hopefully is not a new concept, so I'm going to go through this pretty quickly with you guys. The component coding for radiology is technical component or the professional component or the global component. Hang on. I know I have to have this. I'm going to stop sharing for a second. I should have a slide on this. I think maybe just bear with me for a second. Oh, yeah. Oh, look, I just get to talking and I'm not even remembering what I put on my slide deck. So yeah, I have lots of slides. I've just been on the one side. So here's the slide for the type of service. Here's a slide for what area of the body was imaged. Laterality. Views. Contrast. And components. This is the visual that I was looking for. So our components of radiology services, their technical component includes equipment, supplies, clinical personnel. This is the component that pays for essentially the supplies and the clinical personnel and the actual machine to perform that radiology service, right? The professional component identifies that supervision, interpretation, and report. And that's the doctor actually looking at that X-ray and interpreting it to say, oh, patient has a distal radius fracture, right? Why do we care about these different components? So there are a lot of different ways that you can set up radiology billing. And this is one of the ways that a lot of companies, and like a company that I just recently used to work for, they would perform X-rays, for example. They would like have a patient come in and do an X-ray, and then they would send the X-ray out to a different company, an outside company, to do the read of the X-ray, because our company did not employ radiologists or physicians that were qualified to read X-rays, right? And so in that case, our company billed only for the technical component because we performed the X-ray, right? We own the equipment, we pay for the supplies, we employ the clinical personnel, but we don't read it, right? We didn't read the X-ray. So we sent that off to a separate company, and that separate company did just the supervision, interpretation, and report or interpretation and report of the X-ray service, right? So in that case, my company, right, we're only doing the X-ray portion. We bill with a modifier TC. We get paid about 60% of that charge, that allowed amount, right? However, the company that's doing the read of the X-rays, they bill the exact same code, exact same patient, exact same data service. Or well, yes, this data service on which they performed the read, I should say, with a modifier 26, and they only get paid 40%. That pays for their professional component, right? So sometimes you got to break it up. If it's not broken up and you work for a company or work for a healthcare organization where you perform both the technical and the professional components, you bill it with no modifier, or I should say at least no TC or 26. You very well should probably put an RT or an LT modifier, and you get paid 100%, right? Because you did that global service. I'll stop right there. Do you guys have any questions so far? I feel like I'm just rambling around, rambling away. I could ramble all day long. Got it. Okay, cool. Beautiful. Now let's practice. We don't even need to look at the book here. So let's just, okay, before you even read the top part, I want to give you a trick here. So when you're taking a CPC, CCA, CCS exam, whatever it is, don't read this part first. Look at your choices first. Okay, so we're looking at ABCD. What are some of the things we notice? Well, CPT code is exactly the same. We don't even need to look in the book, right? It's 72132 is our only option. It's got to be the right code. I'm not even going to look it up. But what is different? Well, the components, right? TC, this one has no modifier, this one has both modifiers, and this one has just 26. So this question is just asking us, what component are we billing? We don't even need to look we don't even need to look. Yes, and in the chat, you put C can't be the answer. You don't want 26 and TC on the same thing, then that's the same thing as this one, right? And so C kind of excludes itself, right? So process of elimination, we've only got 3 other possibilities here, A, B, or D. Now let's just scan this note up here and say, okay, well, what component are we billing for? Mr. Jones is sent to the hospital outpatient radiology department for a CT study of the lumbar spine with contrast. The interpretation of the images are performed by the radiologist who's not employed by the hospital. What CPT code should be reported by the radiologist? The radiologist, as it said right here, is performing the interpretation of the images. He's not employed by the hospital. He's only doing that interpretation component. Yeah, exactly. Good job. We're only billing modifier, we're billing modifier 26. That's it, right? So that's a good trick for like a certification exam. Don't read the top, especially if it's really, really long. Just look at the answers and do process of elimination before you even look at the question. Let's do, hang on, let me see if I want to do that one. That one's kind of easy. That's Path and Lab. So we're going to do, let's do this one, and then we'll move to Path and Lab. Okay, so our little trick isn't really going to work too well for this one, right? We have 72084. If we look at these options, there's 72040, 72070, 72100. Goodness gracious, 3 codes. 082 or 083. So what I'm going to do before I even look at the top, I'm just going to go to 72082-ish. And look at them, right? So 72082 is, okay, 72081 is radiologic examination of the spine, entire thoracic and lumbar, including skull, cervical, and sacral spine, if performed, e.g. scoliosis evaluation. 72082 is 72082 is 2 or 3 views. 083 is 4 or 5 views. 084 is a minimum of 6 views. Okay, so this is the entire thoracic and lumbar spine, including skull, cervical, and sacral spine. This is like the whole shebang, right? And then number of views. So what am I looking for here? I'm going to look for number of views. Dr. Booth diagnosed Mrs. Bones with scoliosis and needs her scoliosis measurements. Dr. Booth sends Mrs. Bones to radiology down the hall in the office for an antero-posterior and lateral views of her entire thoracic and lumbar spine. Dr. Booth reads and interprets the scans. Okay, so yeah, we're doing the whole thing. We're doing the global service. It doesn't even matter because there aren't even any modifiers here. And we're doing antero-posterior and lateral views. So how many views is that? 2. So that's going to be reported with 72082. Good job. Hopefully this is kind of, walking through it like this, kind of just when I was taking all of my coding exams, taking lots of coding exams, don't ever, ever, ever read the whole question first. It's just a waste of time. Look at the questions or look at the answers first, and process of elimination, figure out the differences between them, and then look for that detail in the question up here. All right. Take a breath. I'm going to take a breath. We've got about 14 minutes left, and we'll do Path and Lab. So I think we're doing pretty good. Okay, so again, 6 sections of the CPT code book. The pathology and laboratory section is right after radiology. It's got this blue-edged page. You should have a little tab on it. It's on page 577. It's a pretty good section, right? So I mean, pretty good, meaning it's pretty thick, right? There's a lot of procedures here. Now, what we're doing, remember, you have to put yourself in a different mindset for every single one of these sections, right? We're no longer doing diagnostic imaging procedures. We are evaluating specimens. We are taking, and we're not even taking the samples from the patient. We're assuming we have little cassettes. We have little, they call them cassettes. So it's got a little microscope, a slide in there, and we're evaluating that. Or all we have is a tube of blood, and we're evaluating that, or a hair sample, or a tissue sample, whatever the case may be, right? We're not actually taking that biopsy. We're not removing the tissue. We're not collecting the urine. Well, sometimes we could be. Sometimes we're collecting the blood. We'll talk about that. But the codes in pathology and laboratory, this section is just for the evaluation of those specimens. So we're not doing anything to patients. We're only evaluating specimens. And that's kind of what it says here. Codes are different from others in the CPT code book. They're not performed on the patient, but on specimens acquired from the patient. Here on the left-hand side of the screen, it talks about collection, venipuncture, catheterization, and biopsy. Those are going to be reported by the surgery CPT code. Venipuncture is technically a surgical procedure. The code for that is 36415. It's a routine venipuncture. That's when the patient comes in and we, excuse me, stick a needle in their vein and we fill up a tube of blood, right? That is the more than any other surgical procedure, that's going to be the one quote unquote surgery procedure that a laboratory will bill for, right? So sometimes you're going to go to the doctor's office, the doctor will pull the blood with a venipuncture and then send the vials of blood to the lab. Other times the doctor will say, hey, you need to go to the lab, and then the lab will pull the blood via venipuncture, and then they will perform the specimen evaluation. So it just depends on what that process kind of looks like. Sometimes the lab will collect the blood. If that's the case, you bill for the venipuncture. If that's not the case, then you just evaluate the blood. That's all you code for, is just the testing, right? Then you do the complete blood count or the urinalysis or the surgical pathology, and you're only, again, evaluating that specimen. Another thing that's important when it comes to lab codes is the differentiation between qualitative versus quantitative labs. Okay, so a qualitative laboratory study evaluates the quality of a specimen. It's got that root word quality, right? Qualitative. That gives us a positive or negative result. Is it contaminated? Yes or no, right? Is there drugs in this patient's urine? Yes or no? That's a qualitative analysis. Quantitative is different, right? So quantitative has that root word quantity that evaluates examines the, or it evaluates, it quantifies the quantity of a substance in a specimen. That gives us a numerical result, right? So not, hey, is there drugs in this patient's system, but how much of a certain drug is in this patient's system, right? I don't know if that example really holds up for drug tests, but right, it's the way you can tell the difference ultimately is whether the result is positive or negative, as in being qualitative. Is it contaminated? Yes or no? Does it have that substance? Yes or no? That's a qualitative exam. Quantitative gives us a numerical result. Well, how much of said substance is in that patient's sample, right? Other things that are going to impact coding for lab panels, and hopefully you guys already know this about the panels. Panels are important. You can see that I have a paper clip on this molecular pathology gene table because it's like 20 something pages long and I never use it and it's just a waste of my space. So that explains that's just my little pet peeve spot right there, my little paper clip. All right, so I'm gonna zoom in here. Our organ or disease oriented panels. There we go. Okay, so a panel is a group of codes, right? It's a group of, and what am I trying to say? It is a group of CPT laboratory codes or analyses that are all performed at the same time. So like 80047, which one? 80053. Where is 80053? There we go. Now we're looking at 80053 on page 602. So 80053 is a comprehensive metabolic panel. What this does is it's a group of different labs that give us kind of an overall view of that patient's metabolic functioning, right? It includes, and it's up on the screen, but you can see it in the book too, albumin, bilirubin, calcium, carbon dioxide, chloride, creatinine, glucose, phosphatase, potassium, protein, sodium, transferase alanine amino, and transferase aspartate amino, and urea nitrogen. So all of those things are performed as part of the CMP, or comprehensive metabolic panel. Why don't we just report them all separately? It's way easier to just report CPT code 80053 instead of 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14 different codes, right? You would need 3 different HCFA claim forms just to report the labs for this patient, right? If you were billing on paper, I should say. So yeah, it's way easier just to report 80053 than 14 different CPT codes. A couple of rules here is, so it's kind of like a bundle, right? It's kind of like a package, a surgical package. So let's say, for example, we didn't perform the protein. Let's say the lab was out of our protein analysis strips or whatever it is, right? They just, for some reason, their machine was broken. We couldn't do the protein part, but we did everything else. In that case, we cannot bill for the panel, right? If one of those is missing, it kind of breaks apart the entire panel and you have to report everything separately. So yeah, it's all of them have to be performed in order to report the panel code. I'm trying to think of, I feel like I'm forgetting something, but I don't think so. Any questions on panels or anything else lab related so far before I kind of finish up, I guess? Nope. Okay. Okay. Next, surgical pathology. Surgical pathology codes 88300 through 88309 are pretty common. They start on page 693. And what these identify, they're identified based off of levels. So essentially what a surgical pathology code is, let's say, okay, I got my gallbladder removed in December, right before Christmas. And as is the case for essentially every single surgical procedure, they removed that gallbladder. They don't throw it in the trash, right? They don't incinerate it. They send it to surgical pathology. Now, surgical pathology does a pathological examination of all tissues removed from patients, surgical patients, right? So there's different levels of analysis, surgical pathological analysis. 88300 is gross examination only. Gross doesn't mean like, ew, yucky, gross. Gross just means it's with the naked eye, right? They get that gallbladder and they cut it open and they say, yep, there's 2 1 centimeter stones inside of it, or there's 189 stones, or whatever the case may be, right? That's that gross examination only. They do not use a microscope at all. 88032 is a level 2 gross and microscopic examination. 88034, which is a level 3, is also gross and microscopic. The difference between as we go up in these levels, notice they're all gross and microscopic. It's just that they're a different level. It's like a more detailed, intense level of microscopic examination. What I will say here is just be careful whenever you're coding for surgical pathology to make sure that you code for it correctly. In the real world, the pathologist is going to know exactly what level they perform, but in the book and kind of what I have listed out here, sometimes you're going to find the same anatomical location or same body part listed in multiple different levels, right? So just be really careful. So like 88032, you're going to find vaginal mucosa. 88034, you've got vagina biopsy. 88039, you've got total subtotal resection of the vulva, right? So same thing here, you've got uterus with or without ovaries and tubes for prolapse in 88035 level 4. Level 5, you got uterus with or without tubes and ovaries other than neoplastic disease or prolapse. And then in level 6, you got uterus with or without tubes and ovaries for a neoplastic disease. Neoplastic disease meaning cancer. Right. And so just be careful when you're doing surgical pathology, because sometimes like you're going to find skin in all of this. Skin, lots of different surgical pathologies on skin. Commonly performed modifiers, commonly used modifiers, you're going to have the professional component. You're going to have the TC and the 26 for some laboratory and pathology procedures. Some of them do have just the technical component. Some of them will have just that professional component. Depends on what you performed. Reference laboratory, this is called pass-through billing. This is when it's kind of hard to explain, right? So this is like when we get a vial of blood and we send it to the lab, and the lab does a CBC, a complete blood count, and we bill the insurance company $45 for the CBC ourselves because we have an agreement with the lab company. The lab doesn't want to bill the insurance. The lab doesn't want to deal with it. So what the lab does is they just bill us separately, and then we bill the insurance. So we collect from the insurance and give the lab their $45. That's called pass-through billing. I've never actually worked for a company that's done pass-through billing, but it's a thing. And then you've got repeat clinical tests, 91 and 92. We're running out of time, so I'm going to go kind of quick here. Do I want to do that one? Do I want to do that one? Let's do one. Let's do this one. Let's do the hardest one. Deadpool. Oh, Deadpool. This guy was sent to the lab for 80434 insulin tolerance panel for ACTH insufficiency. The provider also added an additional glucose test as well. What is the CPT codes? Didn't even do what I told you guys I was going to do. We didn't look at our question yet. We didn't look at the answers. So if we look at the answers, we got 80434 on 2 of these, 82533, 82947, and then this one has 82947 twice. Okay, so what I would do probably if I was looking at this in a test, so they either have 80434 or 82533, right? So that's kind of where I would start. So I'm going to look up 80434 first and see if I can exclude that. 80434. Okay, so 80434 is an insulin tolerance panel for ACTH insufficiency. This panel must include the following: cortisol and glucose times 5. Okay, so, this is an interesting one. All right. I would say that's the correct code. right? 80434. If we want to double check, let's just double check. 82533. I'm just going to say, I really just want to make sure that's not the right one. 82533 is cortisol. What? It's not even the right code. Yeah, we can definitely exclude B and C because 82533 is not the right one. Okay, so our question here is, we have an additional 82947 here, which is, and if you let me zoom in a little bit here. Zoom. 80434, right? It says the panel must include the following: cortisol, 82533 times 5, and glucose, 82947 times 5. So that's the code for glucose, 82947. We know that's the code for glucose because it just told us that, right? So the question here is, do we code A for that insulin tolerance panel for ACTH insufficiency plus an additional glucose? Or D, do we just code the 80434 for the insulin tolerance panel? What do you guys think? Last question in the chat. Yeah, good job. You are correct. We will bill as A. So in this case, 80434, because we did that whole whopping insulin tolerance panel, right? But then we added an additional glucose test. So the insulin tolerance panel included all 5 of the 82947s included in the panel. But then for whatever reason, our doctor wanted to order one more additional glucose test. So we built 80434 for the whole panel, and then 82947 because that's above and beyond, right? That's in addition to that panel. And that's all she wrote. All right, so that's all I got. How are you guys feeling out there? Any questions, comments, concerns? I know it's a lot of information, but hopefully this is helpful. Any questions? Yes. Do you have a question? Okay. We are done. If you guys want to stick around, please feel free to do so. I'll stay around for questions, but if you do want to drop, please feel free to do so. Oh, the conversion factor. Where do we look that up? That's a good question. Let me stop sharing my screen and I will show you. Well, I mean, I will start sharing my screen. There used to be a way you could look it up on CMS. CMS, not Colorado Medical Society. Hang on a second. I did cms.org, not cms.gov. cms.gov. There we go. I wonder if there's an easy way to find it now. So if you go to cms.gov, go to Medicare, you're going to find a payment. And I'm still not very good at this new website, the way they've done it. There's fee schedules here. This is a really good trick for the real world if you want to see how much Medicare prices out a specific claim for. So if you click on fee schedules, you have an ambulance fee schedule, clinical laboratory fee schedule, DME POS, which is DME supplies, durable medical equipment, and physician fee schedule. So I'm just going to click one of these. There's gonna be a lookup tool somewhere. Lookup tool overview. They always change this. It's like they don't want you to find it. Goodness gracious, where's it at? Lookup tool. Oh, you have to click on the lookup tool overview. I swear they change this every month. And then begin search. You have to agree to the license, the copyright. Okay, so this is going to allow us to identify the billable or the amount that CMS, i.e. Medicare, prices out any code. I shouldn't say any code, but the codes that they do price out. They don't price out every single code. It's only the ones that they cover. So let's just use an office visit code. The year is 2026. QPP is our qualified. Oops. Okay, quit. Yes. What is this? Differential conversion factor will apply to services furnished by who qualifies as a qualifying participant. Okay, I'm just going to say non-QPP. Type of information. So you can have pricing information, relative value units. GPCI is going to be that geographic practice cost index. It's going to differ based off of where you are in your locality. If you're in New York, they're going to pay you different than if you're in Colorado. Okay, 99213. Let's just call it 99213. All modifiers, search fees. This is the only way I've known how to, you could probably Google it, honestly. You could probably just Google it. It'd probably be a lot easier. Because we probably don't have it in this anymore. There we go. Okay. So this is, hang on. Options. Let's say specific locality. I'm going to say I am in Fresno, California. Search fees. It's just going to make our search a little bit cleaner here. Okay, so we're in Fresno, California. We're searching to see how much Medicare is going to pay for 99213. I'm going to scroll down here. It gives us our code 99213. This is the code for our locality. A non-facility price, that's going to be an office visit. Facility price would be like if the procedure was performed at like an outpatient hospital or in the inpatient, something like that, right? And we're billing that facility price. We don't have enough time to go through all of these limiting charges, right? So GPCIs, physical practice expense, malpractice, all that fun stuff. So all of this is an interesting kind of insight into all of the little teeny tiny minute calculations that go into determining how much Medicare will pay for a specific procedure. So all of this stuff, right? So the total price, they're going to pay $99.22 for Fresno, California. That's based off of all of these little teeny tiny value units being, again, multiplied by the conversion factor, which is right here, $33.4009. I guess that's it, right? It's funny because when I first started teaching, I started teaching CPC students in 2011. Wow. You know, the conversion factor was in 2011, it was $36. And this is what, 15 years later, and they're paying $3 less now than they paid 15 years ago for the conversion factor. Interesting. That's why healthcare is a shambles, as you'll see as you get out there. Lots of good jobs, but it's a mess. Hopefully we can fix it. So anyways, that's how I have always found the conversion factor. You could also probably just Google it, but this is kind of more interesting, I think. That's my long answer. Hopefully that helped. Any other questions? Oh, yeah, the practice needed you to do that calculation for anesthesia. So there is the anesthesia fee schedule too. If I go back to where I was, hopefully, I don't know if this helps. I just have to go back. Back. There. Oh no, I guess it is I thought it was anesthesia. It is the physician fee schedule. So if you go back to where we were, you could probably look up, I don't know, well, it lets you look up an anesthesia code. Sorry, I know I'm just kind of rambling at this point, but let's look up 00500. Ah, it doesn't price it. So yeah, it's not priced, which makes sense because it's anesthesia. But at least you've got the conversion factor now. All right. Well, I'm going to stop recording. I hope you guys have a great week 6. If you need anything, please reach out to me and have a great week coding. Have a good week. Thank you. Have a great night. Bye.